It's a pleasure for me to introduce Dr. Hamad Al-Draye. He's a board-certified neurologist, deputy chair of the meeting. He's a very active neurologist and patient supporter and advocate. He contributed more than 5,000 hours of volunteering and participated in over 40 charities inside and outside the Kingdom of Saudi Arabia. He recently represented the Saudi youth in the UNESCO and in that prestigious global event. He is talking to us about one of the research work with insightful results.
Thank you very much, everyone. And with the clinical patient awareness advocacy is very important, so I hope that everyone also keeps in mind that with the INIC, we also work on the MS walk with Dr. Khawaja, so keep an eye open for that. I'll start off by talking a little bit about our research. In coordination with the MS Mimickers, we wanted to look at the real life situation. So are people looking at the MS Mimickers in the right way or not? As specialized people, when it comes to the MS diagnostics, especially neuroimmunology, it's fairly simple. We see enough, we know how they look, and we know what our gut feeling says regarding these cases. But what about the people who are growing up into the field themselves, as in the trainees as well as the general practitioners who sway away from neuroimmunology, for example? We do get a lot of cases referred from outside that are labeled as MS, and the only caveat is it has a white spot on imaging. So how can we look at that in a different perspective? And what does the real-world data say? So research is different, but generally I like this statistic where 1 in 5 misdiagnoses occur in multiple sclerosis, and you can tell that from your experiences. A lot of times you get a referral for MS and then it turns out to be just a white spot or a migraine or a vascular ischemic spot. But we also know that misdiagnosis can also affect the patient. We work with patients to decrease morbidity or mortality, and when we affect the misdiagnoses occur, that affects both. So people, they have, for example, a neurosarcoid, and we fail to recognize it early on, that would affect the patient's progression. Or if we say this is not MS and then turns out to be MS, the disability and progression grows on and on. And what does this research want to do is it wants to look at neurology education, which is something I'm very passionate about. How can we properly educate people in the next generation, especially in a new field generally when it comes to neuroimmunology, and also looking at our general important task, which is diagnostic accuracy. As doctors, we're supposed to diagnose, then treat, not treat without diagnosing properly. And finally, patient's sake, we want to make sure that we are safe for the patient. Again, that's 20%, which is 1 in 5, as well as other very common mimics, just as neuromyelitis optica, CNS vasculitis, and other mimickers. And when we look at the general idea of this concept, we do also have to realize that we have primary, secondary, and tertiary, where tertiary you see a lot of MS, neuroimmunology, neurosarcoid, rare diseases, uncommon and common. But when it comes to the non-tertiary, that number drops and people don't really see what we see. The most they see is MS. If they see something different, they do see it, but they do not recognize it. And then it transfers to us, and then we get to recognize that. So that there is a gap on itself. The second is when it looks like at specialized and non-specialized training. We do need to also realize that there's a lot of places that do not have specialized training, which means to say the advanced MRIs, other resources, other staff members, and other technologies that can help identify and actually see the process of diagnosing MS. And these are the gaps that we're trying to look at. Again, it reflects what we discussed previously, but we wanted to identify that into a more proper objective-based research. So we're looking at people who can identify the red flags, which is a very important thing. And as you can notice, it's before the McDonald's criteria. So I want to make sure people know the red flag before they know the McDonald's criteria in itself. The second thing is McDonald's criteria by definition. It's the best guideline to get people to know if this is MS or not. And by definition, you need to rule out the red flags first. Then we want to look at hallmark presentation. So if I don't know what neurosarcoidosis is, but I do recognize the waterfall sign, then I'm kind of pinpointing the hallmark. And finally, with the safety and the best answer we can say in medicine, I don't know. And I want to see how much people would say I don't know. It's a cross-sectional study. We took about 80 neurologists. It's not the best sample, to be very honest, but it was something to trial and pilot. We took 3 people from each PGY year, and we took it from 3 centers. Each center is a different specialty, so primary, secondary, and tertiary. And we reviewed about 42 images, each one appearing 3 times in the process. So they saw MS and MS mimickers, such as NMO, MOGAD, neurosarcoid, CNS vasculitis, and other mimickers. The people would then be having a form on the side. They would choose one of the 4 answers. Clearly MS, which means I'm very confident. Not MS, which means I'm confident it is not MS, but I don't know what it is. And then I can also identify a specific MS mimicker. So I can say this is not MS, this is neurosarcoid, or I don't know with a specific justification, so we can know what people are thinking. The materials used were MRI and spine images from real-world cases. Data collection was, again, a very simple form. Statistical software was just a basic Excel and other source of visualization. And this is most important for me. So I wanted to look at 4 types of analysis. So first I want to describe what I saw. So what's the mean accuracy rate? What are the trends, depending on the levels and such? So just a general description. But I also wanted to look at comparative analysis. So using the statistical models, the ANOVA, the chi-square, and the other correlation tests to have a better look at what the data says in a more definite analysis. But also on top of that, I wanted to do 2 more specific analysis, which is more interesting to me. So something thematic. So what is the theme that is happening for what they're thinking about, how their cognitive thinking is going on. And that's the open-ended questions, how it helped us find that. And finally, the error analysis. So I'm more concerned about the errors rather than the correct answers. So these are the sheet. Again, very basic research, but the insight is very wonderful. So first objective, can they identify red flags? So you can notice that PG1s correctly identify about 11 cases on average. And as they progress above or higher, they become more significantly identifying more. So the PGYs at the end started to diagnose more than 25 cases. But as you remember, 42 were the number of the cases. So even with the PGYs getting 25 correct, which is one of the highest, it's still half or almost half of what they noticed. And the PGYs got 10, which is about a fifth or a quarter of the answers. So we do find that there's an issue with identifying red flags. And I found that to be interesting because it's 2 things. One, they jump into the McDonald's criteria directly, or they forget to notice what really defines a red flag. So we know them by thought, but if we want to list them down, we get this mind. This is exactly what I'm getting, the loss of words. The second one is using the McDonald's criteria, which again, I hope that it would be exactly easy to do, but again, 15 cases were correctly used when it comes to PGY1, which goes to their start of their training, trying to get things going, but also they already know it from the College of Medicine, so they should be applying it better. So that tells us there's an issue applying the McDonald's criteria rather than just memorizing the McDonald's criteria. But then that goes up to 33 when it comes to the PGY 5s and 6, which is a relatively good number. When it comes to finding the hallmarks, they steadily go higher, but as you can notice, they are very nice numbers. That's an error that's 39, not 59. Anyways, the steady high number is good, but I don't like this graph because this tells me that people memorize more than they know, because we memorize these things, especially when exams become harder and harder. The hallmarks and the rares and the uncommon become very big points in examination. So I refer this to more of a preparation for the boards rather than an actual experience of finding these neurosarcoids, mimics, CNS vasculitis, and whatnot. Choosing I don't know, it's an opposite. The more junior you are, the more you say I don't know. The more senior you are, the less you say I don't know, which this shows how confidence grows, but the ego also grows with this confidence. So that just tells you that we need to also modulate the confidence, because that increases error to prone, or make them prone to error. And if we look at the next slide, this shows how much there's a distribution between the PGY1s and the 3 and the 4, and the 5 as well. But again, when I mentioned earlier, the sample size and the study sample is not the best. That just tells me that we need to look at more detail. So this gap needs to be further designed into gender-based, location-based, different kind of aspects that can help us to really understand what that gap means. Again, here is the same thing, but when it comes to the PGYs, relatively the gap is not that huge. This is more in the beginning. And this also rather than just the demographics, I also want to know about the lifestyle, what happens to these people and their training, because training is very dynamic. And I want to know what's happening in this dynamic process that allows them to give these results. So the summary, again, the ANOVA chi-square Spearman correlation, they all showed confirming strong association and positive correlation. Again, with the sample size, they still do show that there's a statistical correlation to all of this. And my favorite part is the error analysis. So these, again, are the data that we used. When we look at the error analysis, it goes down as they progress, but I love seeing the PGY5 jumping up. And this is what I call the senior bump. So when we become senior at the PGY5, we think we're all that, we're consultants, we're ready to take on the world. And then we get hit with the reality that no, we still do make mistakes, we still have a lot to learn, and then we go down and become more humble. So what did the error analysis show? It showed that the vascular hyperintensity were one of the biggest mistakes, and that came more from the primary centers. The neuromyelitis optica and other neuroimmunology or rheumatological diseases that occur, that cause white matter disease, were also causing some error issues, mostly because, again, they focused on the MRI and they forgot to have a better look on the spinal cord. And that kind of reflects also our training and our setting, where we focus mostly on the MRI and we screen the spine real quickly. And we'll just look for a long segment or a short segment, and we don't really give them that much of attention as we give attention to the brain. The anti-MOG and ADEM were also confused because of the enhancing pattern, which is something very typical, especially for young physicians. And overcalling MS was, as we mentioned, a sign of confidence or safety. When it comes to the factors that contribute, so the lesion misinterpretation was the highest as they go in the first segment, PGY1, 2, 3, again, because they really don't know what they're looking at. Failure to recognize the hallmark was significantly improving as they go up PGY 5 and 6. Again, I refer that more to the boards and studying and getting more academic preparations. And overcalling versus undercalling is a trend that we also noticed when it comes to confidence and safety. And limited exposure to rare mimics is also an important thing. It's similar to all types of centers because, again, tertiary you see more. But even if you're in a tertiary care center, when you're first or second or third, you don't have that much exposure. And even if you're exposed, you don't know what you're looking at. So even if you see a neurosarcoid, you still don't have the mental picture of what that is. So again, as I mentioned, this is a small sample. A multi-center study may not reflect the global trends that's happening on neurology training. Again, even with different centers, the level of care is consistent when it comes to secondary, tertiary, primary. But it's different when it comes to the aspect of how the training is conducted. So you can have a tertiary care center that is training heavily, and you have a tertiary care center that's training in low quality. Selection bias is a very important thing to think of, because I chose people that I know personally because I wanted to pilot the study, and the lack of real-time decision making. So they were having free time, they were on their laptops, easy to look at these things. Their recommendation is basically to make it stronger, to make people exposed to more mimics, to standardize the MS imaging training. We take it for granted that McDonald's criteria is simple. it's 4 or 5 questions, but we test them on it again and again, but do we actually apply the teaching on them? AI is also good because it's all based on AI pattern recognition. So can we give them an AI tool to support them as they go on? And we also need to look at the balancing the confidence and the caution, because that's something we noted in the research. And at this, I close my lecture, and I thank you for your time.
Thank you very much, Dr. Hamad, for such an insightful work. I totally agree. It's important work, and maybe if replicated with a larger sample, it will give us even more insight. Please join us.
I have another question or comment to Dr. Adiri about your talk about, residents identifying MS. And I think, first of all, the biggest factor that residents always forget about the McDonald criteria is one of the conditions is excluding alternative causes. And I think constantly reminding them of that. The other issue that I think we have to emphasize on all our trainees, that it's worse to be a physician who doesn't know that they don't know or doesn't understand their limitation than admitting that you don't know what to do, because the impact of diagnosing somebody and then undiagnosing them is such a huge factor.
Yeah, I totally concur with you, Ghada. Thank you for this comment. And I tried to, during my practice, I always try to show the trainees that it's very okay to not be sure. It's very okay to seek opinion from your colleagues, and that you shouldn't, think about your ego when you do this, because at the end of the day, you are the ultimate responsible for this patient diagnosis and long-term management. So I can't agree more with what you said, and that also it connects me to, or takes me to my question to Dr. AlDraye. Importantly, how many of these residents knew that or entertained the possibility of wrong diagnoses at the beginning? Because you showed that in the slide, but I wanted to hear more from you about this.
So, yeah, all these comments are important. I think the main 2 concepts here is we take it for granted. We think it's McDonald's criteria. It's a very simple checklist when actually it needs a lot of cognition and active critical thinking. And with that, there's a big area of cognitive bias or cognitive errors. And if we don't acknowledge that, then that gives us a lot of room for error. And again, I always tell people that my favorite answer is I don't know. And the second thing is, when you're done with your clinic, you're going to get a coffee and you're going to have fun, but the patients are going to live with the words that you say. So you need to make sure that it's the right words. All of them knew that they're going to see MS patients and MS mimickers. They knew that they're going to see MRI brains and spines, and they had the luxury of free time. So it's not really time locked to how much they can see the image. It was based on how they wanted to see the image, how long they wanted to take, what kind of image they wanted to see first. And that luxury of time and autonomy in choosing the image is the things we wanted to give them the space to do, because at the end of the day, they're supposed to find the information and then give the decision. So they were very, they acknowledged that there's an MS and MS mimicker in the mix.
What I found the most comforting in your study is the impression that the residents are learning over time.
Exactly.
And because there are times where you have problems and you say, gee, when are they going to get that point? And here you demonstrate very well the improvement with time. Congratulations.
Exactly. I think that goes on just a shift in medical education. We used to go a time-based, so if you finish the year, then you are privileged to go to the next level, and now we're going to more EPAs, which is the entrustable practice. So more if you're entrusted with the practice, then you get to go to the next level. So if I can entrust them to use the McDonald's criteria properly, see the mimickers, make proper diagnoses, then I'm able to actually give them the privilege of becoming more and more senior. And that's something we also identified here.
Professor AlDraye, you've taught.
Thank you very much, everyone.
Thank you.